Good afternoon. Let's do a quick syllabus check. Okay, so schedule check. So today we're going to get into endocrine disorders, but first we're going to cover this last little section. And we have post-quiz this Friday, and then next week, Monday is Veterans Day. So the university's closed, we don't have class, and you essentially have a week to study. There's no new content, there's no pre-quizzes, there's no post-quizzes next week. And then, so 2 weeks from today, the next time we see each other, is exam 2. Does that make sense? Okay. So, Karen and I met this morning. There's going to be a lot of activity next week. You don't have the whole week off, so nothing dramatic is happening other than just a holiday on Monday. So that affects our class. And it affects it really in 2 ways. And so I debated on putting online content for next week, but I held off because I don't want to pile too much on the next exam. So that makes it content-wise. So you're going to have a study week, which is kind of nice. But it impacts us because the last section after exam 2, we've got renal, liver, respiratory, and heart to cover in essentially 2 weeks. So we're going to do renal and liver in 1 week, and we'll do respiratory and cardio in the second week. Renal and liver we can get through in 1 meeting. Respiratory and cardiovascular, there's no way to get through it in 1 meeting. So you're going to do your respiratory lecture online, and your cardio we're going to do in person, okay? So that's kind of how it affects us this semester. Now you know that that respiratory content is open. Some of you might decide to do it next week. Some of you might think, I am not going to confuse myself before the exam and go over material that's not on the next exam. I understand that. But then after the exam on the 19th, you don't have anything else for the rest of the week. It is Thanksgiving week. But in between pumpkin pie, maybe, and hot cocoa, you might decide to do the respiratory lecture. You'll have the exam behind you, okay? You might be doing some shopping, in a food coma. Maybe you could decide to do some of the respiratory work ahead of time. You with me? If you wait until you get back, that's your choice. There's just going to be a lot to do in those 2 weeks when we get back from Thanksgiving.
What about an eggnog hangover?
Eggnog hangover, I heard a great solution for that is a respiratory lecture. Thank you for bringing that up. Okay. All right, so any questions about what's going on next week? Or how the rest of the semester looks? I mean, really, we're winding things down pretty fast. So, okay. I got a couple questions for you. What do you call the hair underneath the cow's nose? The hair underneath the cow's nose. A moustache. Very good. Well done. What kind of fruit has the most electricity in it? What kind of fruit has the most electricity in it? What?
Yeah, there's like what fruit?
Oh, what fruit? Okay. Because you were close. But it's watermelon. Make sense? Okay. Why are animals in the ocean so healthy? Why are animals in the ocean so healthy? They get their daily dose of vitamin C. All right. See, these are more for me than you, to be honest. They're my way of putting my entire day behind me, turning it off so that I can focus on spending some time with you guys. Whoa. Okay. So what we need to finish up is the cancer lecture. There's been lots of emails, lots of conversations in my office about the past 2 lectures because inevitably they seem to affect or impact quite a few students. You know, everyone seems to have a family member or a friend that has struggled with either a nervous system disorder and or cancer. They're pretty broad-based. At the last portion of the cancer lecture, we can talk about these incidence rates, and we alluded to these things. And this is an old slide. It's old data, but the percentages, the relative percentages haven't changed really at all. The numbers have gone up. Pretty much the numbers, volume-wise, of cancer has increased because the population of the world is increasing. But the relative percentages have stayed about the same. So you can see on the left part of the slide, prostate cancer at 25% is the #1 cancer that men wrestle with. And the contrast or the comparator for females is breast cancer. And you know, these are kind of the two #1 killers, if you will, with respect to men and women. You can see how things are divided out amongst men and women. It's actually pretty similar with some of the others, like skin cancer, lung cancer. Pancreatic cancer tends to be a low percentage. It tends to mostly affect men, but it's still in a low percentage. But pancreatic cancer is one of the most aggressive types of cancers that men can get. So prostate cancer can have a fairly good prognosis if it's caught early enough. And there's a lot of survivors of prostate cancer. In contrast, pancreatic cancer is kind of one of the bad ones. It's hard to catch it early, and when you detect it, a lot of times it's stage 4, meaning it's already broken off and gone somewhere else. It's already metastasized.
In fact, Steve Jobs died of pancreatic cancer.
That's correct. Steve Jobs did pass away from pancreatic cancer. That's correct. You know, and he had a lot of resources available to him, right? And so it just went undetected, even though he had a lot of resources available to him. He was actually fairly health conscious. It didn't show up early enough where he could actually find it. So we also want to chat a little bit about carcinogens, okay? Cancer-causing agents. And carcinogens can cause a mutation. And when that mutation actually occurs within the DNA, and if it occurs within the germline of the DNA, then it's a heritable trait. It can be passed on. But when it occurs in the adult line, it's not heritable, but it can be impactful to that organism. And we experience all sorts of different types of mutagens in the form of a carcinogen in our daily life. Right? All of us are exposed to ionizing radiation. All of us are exposed at some level to sunlight. We have certain concentration of chemicals that we interact with or that we're exposed to on a daily basis. There are certain states that are much more prevalent about announcing what those carcinogenic agents are or those mutagens are. The state of California, for example, if any of you are from California or visit California on a regular basis, there's a lot of signage about, because there's state laws about publicly disclosing what some of these carcinogenic or mutagenic agents are. So there are some other things that are less obvious, and you don't see any signage even in the state of California on some of these. For example, chronic inflammation. Chronic inflammation can cause a mutation. A viral or a bacterial infection can cause a mutation. Environmental is the list that you usually see. Okay? Environmental agents are usually the ones that are identified by name, whether they're pesticides, whether they're preservatives, okay, whether they're carcinogenic agents that are found like in tobacco smoke. So we're going to talk about each of these, but we're going to talk mostly about the ones that are a little bit less understood or less prominent or less in the public eye. So the question that I want to pose on this slide is, how can chronic inflammation contribute to cancer? And I'm going to remind you of our first lecture, the first time we were together. And what was the clinical disease that we looked at as one of our first examples in the very first day? Esophagus. So who can explain to us or remind us of Barrett esophagus? What was going on there? How did we get to Barrett?
Because of the chronic influx of acid deteriorating the lining of the esophagus, it causes cells up there to form a dysplasia.
Metaplasia. Yep.
Metaplasia
Yep.
to really squash.
They were squamous.
The worst of
They became what? Columnar, goblet containing columnar, right? Goblet cell containing columnar. That's right, that's exactly right. You guys hear that in the back? So we've got this irritation from the stomach acid that's coming up, and there's chronic inflammation that acid will trigger. If you don't believe me, just pour a little acid on your skin and wait a little while, and you'll see inflammation show up. Okay, and it'll be there for a few days too. Okay. So that irritation, that chronic inflammation, first leads to this metaplastic response where it changes cell types. It tries to respond to it. But if the gastroesophageal reflux disease or the acid reflux keeps occurring, we said that those patients were at a higher risk of developing what? We said cancer. We used a fancy cancer word. An adenocarcinoma, and it was of the esophageal nature, right? So it's esophageal adenocarcinoma. So like the first day you thought, holy crap, you just used a really big word. I don't even know how to spell that. Now all of you are like, oh, yeah, I totally understand what that means, right? An esophageal adenocarcinoma. Sounds fancy, kind of scary, but that's a perfect example of how chronic inflammation can contribute to a mutagenic change at the level of the DNA. Now, what suppressors might be bypassed in order for this adenocarcinoma to show up in the esophagus? What suppressors from the last lecture might be bypassed? What's that?
P53.
Maybe P53? What else?
RB.
Maybe retinoblastoma, RB, okay? A tumor suppressor gene that's supposed to catch it, it might be bypassed, and now all of a sudden the mutation is replicated. And now all of a sudden you have a neoplasia, a new growth. Does this make sense? So I'm speaking pathologies, right? And you guys are tracking with me. That means that you probably learned something this semester. It's kind of cool. The beginning, the first day, if I just said that sentence, you'd be like, what's he talking about? Okay. Is he using English? So you guys are tracking with me. You understand exactly what we're talking about. We just wove in tumor suppressor genes by name. You're nodding your head because you're like, I know exactly how they act. They reinforce a gap phase, right? Like gap 1 to pause replication to check the integrity of the DNA, and they would find that mutation that happened at the DNA level before they replicated. And that's normally how it's supposed to happen. So that's why it takes maybe 10, 15 years for chronic GERD to trigger an adenocarcinoma. Because if you trigger mutations enough, give it enough time, you eventually might miss one. You with me? You may not catch it, and it actually gets propagated. And now all of a sudden you get this cell cycle checkpoint that's compromised. So there's a list here of pretty common ones that you'll see in the literature. Ulcerative colitis. Okay, people that have like IBS are at higher risk. Please understand, I'm not saying if somebody wrestles with IBS or Crohn's disease that they're going to get colon cancer. But are they at higher risk of maybe developing that? Yes. Okay. Now, the more they manage it, the less the risk is, or the risk goes down. But you can see this sort of cause and effect between an inflammatory disease and what the cancer mutation might materialize as. Ulcerative colitis. Patients will develop colon cancer if it's left unchecked, it's not managed very well, and they're unfortunate. Okay, there's a little bit of bad luck involved in this too. Chronic asthma, asthmatics, those that wrestle with asthma. Now, the thing with asthmatics is typically it's not chronic. You're not wheezing 24/7. You have asthma, and when it flares up, you use a rescue inhaler. Or maybe you're on a daily medication to keep your airways dilated. That's not chronic asthma. Chronic asthma is when you're unmanaged and you're just living with the symptoms. You with me? So it's important to manage those symptoms in asthma, and that's why there's all this public information about managing asthma symptoms, and there's new medications that are daily medications that you can take, so you don't have to reach for that rescue inhaler. And then we can potentially lower the chances of developing lung cancer. So any type of smoldering inflammation within a tissue, if gone unchecked, could actually trigger a mutation at the level of the DNA. Now, these inflammatory cells, let's remind ourselves of what they do. So if there's an inflammatory event, which are typically the first cells that show up in that tissue? Neutrophils. And then they're shortly followed by tissue macrophages that came out of the circulation, and they were circulating what? Monocytes, okay? When those cells, those inflammatory mediators, those cells get to that tissue location, they can release all sorts of different types of chemical signals, known as cytokines. Growth factors and cytokines that help to recruit additional macrophages. They help to recruit maybe fibroblasts in the skin to try to lay down new collagen. Now, they also, if they're macrophages and they're activated, they also have the ability to phagocytose like bacteria or some foreign object. And through this respiratory burst mechanism, they manufacture in a vesicle reactive oxygen species and nitric oxide. Remember that? And that's the tool that they use, or the weapon that they use to actually kill that foreign object. Now, if the bacteria, if this is a smoldering inflammatory event, meaning it's chronic, do you think there's any leaky ROSs that make it out to the tissue?
Yes.
Yes. And what could they do to the DNA as free radicals? They could cause damage to the DNA. Okay? So, inflammation is beneficial in order to promote healing. But if you let it smolder or go long term, you can see how this could be a problem at the level of the tissue and eventually within the cell at the level of the DNA. Does that make sense? COX-2 is an enzyme that is responsible for inflammation and pain. There's a close connection between inflammation and pain. And we use COX-2 inhibitors to actually lower inflammation and to block its activity. Medications like aspirin, for example. Now, COX-2, if it's elevated in a chronic inflammatory event, then inflammation is persisting long term. And some of the epidemiological studies have actually shown that high levels of COX-2 long term are very closely correlated with diseases like colon cancer. And so in these patients, a lot of the cancer that ensues, it's a little bit of a question of, is it due to COX-2 levels being high, or is it more of a, chicken and the egg argument where we can't really know what causes what? But we know that COX-2 is an inflammatory mediator. We know it's upregulated in a lot of chronic diseases, and we see it very closely paralleled to certain types of cancers, specifically colon cancer. Okay, so some pre-cancer lifestyle modifications are looking at prescribing COX-2 inhibitors to keep those levels down, okay, in those older patients. Okay, infections and viruses. Okay, so we can be infected with either a bacteria or a virus. Let's talk about viruses first, and then we'll get to the bacteria. So the viruses themselves have the ability to integrate into the host genome. And there's a few that are very, very concerning. So hepatitis. Hepatitis B and C form. A lot of times will mutate at the level of the host genome, and because they target the liver cells, the hepatocytes, these patients are at higher risk of developing liver cancer. And Hep C specifically is extremely dangerous. And it's not uncommon for a patient to be hepatitis C positive and carry Hep C for most of their life, and then later in life develop liver cancer because of the Hep C. Okay? So it's not necessarily liver complications due to the hepatitis virus. It's because it mutates into the genome, and now the hepatocytes start growing lesions or tumors in the liver itself. HPV, that's the human papillomavirus. There's a vaccine against this now. This has actually been very controversial. The vaccine is typically delivered pre-adolescence into the early ages of adolescence in females. And the reason for it is because the HPV virus is highly mutagenic, and it targets the cervix in tissue in females and can cause higher incidence of cervical cancer. So now young ladies can actually be vaccinated against HPV to try to lower their risk of developing cervical cancer later in life. Pretty new. This is, my kids have been exposed to this vaccine, but when I was a kid, I don't believe that these vaccines were available for HPV and being prescribed in high volumes like they are today.
Males are also vaccinated.
Males are vaccinated too?
Yep.
Okay. I wouldn't know that because I only have daughters. So, and because I know they all have cervixes, I say, yeah, we should probably get them all vaccinated. So. But males are being vaccinated for it, okay. So obviously it doesn't target the cervix. Where does it target in males?
They get penile cancer and throat cancer.
Wow, that's two areas that are very far apart. Okay. All right. Penile cancer sounds horrible. Throat cancer doesn't sound any better. So, yeah, okay. So I didn't know that. I learned that. That's good. So kids are getting vaccinated for HPV now. HIV. HIV, this virus, as you all know, is highly mutagenic and leads to these Kaposi sarcomas. And this is a systemic disease that presents itself at the skin with these lesions. And it was very popularized in the 1980s, these skin lesions, these Kaposi sarcomas, is kind of the AIDS skin disease, is what they would say. End-stage patients develop these lesions, these sarcomas on their skin. And because the HIV virus tends to take residence in the skin amongst other places with the T helper cells, and it mutates at the level of the genome and starts creating these neoplasias in the form of a Kaposi sarcoma. They also will develop non-Hodgkin lymphoma. This is a cancer of the lymph tissue. Very, very prevalent in AIDS patients, end-stage AIDS patients. So you can see here with viruses, the concern about the virus is that, especially when they're highly mutagenic viruses, like the ones that we've listed here, we see close association with cancer or tumor lesions being formed as a result of the mutation of the virus inserting its own DNA into the recipient. Okay? The flu is highly mutagenic. Don't know of cancer or flu-caused lesions that have shown up in the medical community as of yet. In the future, is it something that could show up? It's possible. It's highly mutagenic. It's very prevalent, and diseases seem to evolve. And so that would be something quite amazing that our human race would actually have to battle, right? Figure out how to navigate cancer-causing flu, right? Sounds like a great, like John Grisham book, like a novel, sci-fi novel. Go ahead.
Would you believe that the flu could be more likely to be a carcinogen, with all the vaccination going on, that sort of forces it to mutate more, or has it always been mutagenic?
It's always been it's always gone through a high mutation rate. Now the question in the medical literature today is the rate increasing? And it depends on whose mail you read. It's probably pretty consistent. Can mutation rates increase in certain viruses? Absolutely. And so if it continued to increase, and evolve. I don't know what would happen. It's hard to guess. But it's a fascinating mental exercise to think about how dangerous that would look like, right? Okay, let's shift to bacteria. So the bacteria example that I want to talk about is the H. pylori. So this helicobacteria, this is the far right slide of the screen. You can see in the upper right an image of this bacteria. That's that white ghost-looking image in the upper right. And this H. pylori tends to target the antrum and the pylorus of the stomach and the early part of the small intestine. And it takes residence in the stomach and in the distal portion of the pylorus and causes a smoldering infection. And what it's closely associated with is stomach ulcers or small intestinal ulcers, duodenal ulcers. And they will persist, and they're bleeding ulcers. So you can see this imagery at the level of the antrum and the pylorus in the stomach to the duodenum. And left unchecked with these stomach or duodenal ulcers, we can cause mutations to take place and the development of stomach cancer or duodenal cancer, small intestinal cancer. So it operates very similar to a virus, but it is a bacteria, but it tends to sort of insert itself into the invaginations of the gastric mucosa. And you can appreciate here, these are inflammatory cells that are migrating out towards this bacterial infection. And this is what leads to this ulceration that takes place in the form of resulting chronic inflammation. Okay? So, similar outcome, whether it's a virus, certain viruses, or certain types of bacteria. And the H. pylori are particularly problematic because it's difficult to rid that stomach lining of that bacteria. It's not in the system. It's technically outside the body. It's almost like it's stuck between your big toe and your second toe. Does that make sense? So you don't have direct access to it. And that's one of the reasons it's kind of complicated to treat. Okay, let's talk about environmental. So these are placards that you see all over certain parts of the world. I'm picking on California, but they are a great example, and they're kind of easy to pick up. Okay, so I know if you're from California, I apologize, but you've all gotten into like an elevator, right? At like a Marriott in California, and there's like this big red sign that talks about all the carcinogenic agents that are in the elevator shaft. You're like, they're probably the same ones that are in every other elevator shaft in 49 states, but there's no placard there. Okay? So we've got things that can contribute to cancer that are really in this environmental category. Ionizing radiation, UV radiation, asbestos, air pollution, electromagnetic fields, and then tobacco. Many of you don't have a lot of experience with asbestos, but like when I was growing up, asbestos was actually much more commonplace. Believe it or not, in this building there is asbestos. It's old enough that it does have asbestos. So whether you like it or if we're in California, they probably signage, right? When you walk in the door, okay? You're walking into an asbestos building, right? But some of the tiles, the old tiles on floor tiles in this building, have asbestos within them. And they're fine as long as you don't disturb it. It's just when you need to remodel and pull the asbestos out that it can become airborne. And the problem with the asbestos is they're microparticles that can actually get trapped in your lungs and in the deep alveoli within the lungs and cause an inflammatory reaction there. Okay, very similar to this H. pylori. So that's what asbestos is all about. But air pollution can do this just as easily, right? So I usually get this question in the respiratory section, so we'll talk about it a little bit now because we're getting into tobacco. If you can see the air that you breathe, you probably shouldn't be breathing it. Does that make sense? We weren't really designed to breathe air that's visible. So if you are in a city that has polluted air and you can visibly see the air, like when you drive in, you're like, wow, it's like gray over the city, right? That's probably air that has stuff in it, particles, that shouldn't be in your lungs, as a general rule of thumb, okay? It's supposed to be translucent, like you should be able to see it. So the same thing goes with cigarette smoke, right? And so what about vaping? I always get these questions about vaping. Well, the same thing about vaping. It's early. We don't understand all there is about vaping. Has it eliminated a lot of the carcinogens that traditional cigarettes have? Yes. But are there still particles that are there? Yes. Are they good for you? I don't know. Is it better not to have them in you? Probably. Okay. Is it less risky than smoking a traditional cigarette? Probably. Okay. So, there's no hard and fast rules, and there's this huge debate, but just remember, when I was growing up, this tobacco companies swore, pinky promise, put their hand on the Bible, swore on their mom's grave, that there was nothing dangerous about cigarette smoke. They had their fingers crossed. Right? So I am dead serious. There's lots of documentation, like in front of Congress. These CEOs were saying that there wasn't any evidence that they discovered that it was bad for you. So we just don't know yet. Okay, we just don't know the answer on vaping. Okay. Also, cell phones. So ionizing radiation. You can find these ionizing radiations in all sorts of different places. Okay, you can find it around power lines. Electromagnetic fields can actually attract certain higher concentrations of pollutants. So is there an electromagnetic field that's created from your cell phone? Yes. Okay. Is it high energy? Probably not. But the amount of time that we spend on those devices near our tissues is pretty high. And to be honest, it's only been about a decade that it's been at this level of usage. Right? So you guys can probably remember, you're probably old enough to remember 10 years ago, the phones were very different. Right? And so people didn't have them on themselves 24/7. 20 years ago, the cell phones were very different. Right? And 30 years ago, there were hardly cell phones. They were like car phones. Okay? So we have these devices that are near us on a regular basis. They're either in a pocket, they're on our hip, they're in our pocket, they're in our back pocket, right? They're at our ear. Well, even if you do a Bluetooth technology, yeah, it's smaller, but there's still some sort of electromagnetic energy that's around that device. So we don't know the answer. That's why there's these big question marks. I think in your lifetime, probably even in mine, but definitely in your lifetime, more data is going to become available that's going to be eye-opening about health complications associated with cell phone usage as well as vaping. You've already seen some data coming out about cell phone usage, right? And it's actually targeting children and adolescents, and it's talking about a higher correlation between cell phone usage, screen time, and depression. Have you guys seen these recent publications in our adolescent population? The amount of screen usage goes up, and depression rates go up with it. Now, it's not cause and effect data, right? That's epidemiological data, where you're actually just tracking two populations of usage or statistics, but it's pretty concerning. It's pretty concerning. And, of course, we don't go too far down this rabbit hole, but, there's this whole element of social media that's woven into the screen time usage, and I think there's probably some crossover between interactions. It's not just screen time per se. I'm sure there's other factors of screen time too. But these are things that we didn't have that when I was a kid. Okay? If you're gonna get bullied, you just got put up and picked up and put in a trash can. Someone just punched you in the face, right? I mean, it was over pretty fast. It wasn't like, all year long that they're dealing with this stuff. So there are new health concerns that we have today that I don't have the answer for you, but you'll probably be elucidating these in your career. And I went back when I was a kid, there was still this debate if cigarettes were actually bad for you. I can remember going and visiting my dad in his office, and he had an ashtray on his desk. And he didn't smoke, but all of his clients smoked. So they would come into his office, and he had cigarettes, and he had pipes, and he had cigars, because if they wanted a smoke or tobacco and they didn't bring it with them, then he had it there. Like, it's like, would you like a bottle of water? Like today, would you like a bottle of water when someone comes into, you go to Discount Tire and they offer you a bottle of water, right? You're like, would you like to smoke? And that's how it was. It was kind of part of doing business. And you guys are all like, what? Yeah, well, wind the clock back or forward like 30 years where you're like, yeah, people would, drive down the road and you would look through the window and you couldn't even see the person. There was so much smoke in the car, right? They'd roll down the window and it was like Cheech and Chong. It was awful smoke, right? But they were vaping. They're not doing anything other than vaping, and they didn't realize how bad that was for them. Who knows? Maybe it causes eye cancer for all we know. I don't know. Okay. Is there a question? Okay. I got a little bit off on a tangent. Let's just finish this up, and I want to show you how there's some correlation that's very concerning. Okay. So there's over 30 known carcinogens in tobacco smoke. This is traditional tobacco smoke. Okay, so vaping, obviously, I agree. The argument that there's far less carcinogens in vape smoke, I agree, that is true. I still don't know if it's safe for you, and I would argue it's probably not as good as just breathing in Flagstaff air, okay? But 30% of all cancers are associated with carcinogens that are found in tobacco smoke. And there's many different types of cancers. These include renal, penis, bladder, oral cavity cancers, lungs, esophagus, stomach, liver, kidney, pancreatic, cervix, uterus, myeloid leukemia. And the data that's most concerning is when you look at the combined effects of smoking with alcohol consumption. And so what I want to show you on this graph is, and a lot of these things could be looked at in this kind of interaction. But this graph just looked at alcohol consumption here in grams per day, and then tobacco smoke in these colored bars, 0 to 7 cigarettes a day, 8 to 15, 16 to 25. How many's in a pack? Is it 20 in a pack? You guys even know? This is probably the wrong audience to ask, right? You all have friends that know this answer, right? I thought it was 20. So it used to be like a half pack a day. So and so was a half pack a day smoker. So and so was a pack and a half a day smoker. That's how they used to classify patients. So I don't know why it's. I think it's 20. So I think this kind of peach paint color over to this more magenta color. This is probably right on the cusp of a pack a day. And then here's our relative risk. And so what you can see is the more alcohol, which is the 120 plus grams per day. I don't know the grams of a beer. So I think they're trying to make this more universal and less, focused on your behaviors, just more seeing the interaction. So if you're at about 120 grams per day of alcohol consumption, so you're daily consuming alcohol, and then you go out to like the magenta color or the purple, and you look at your relative risk, this is significantly increased over kind of light use is the take-home message. And so you can combine these with all sorts of different types of activities that could be dangerous, right? And so, just as you learn and as you move on in your professional development, you'll probably be able to see and pay attention to data that comes out like this of risky behaviors as you group them together. And there's a lot of overlap between cigarette use as well as alcohol consumption. They a lot of times go hand in hand, especially when they're done in excess. Okay. Question for you. Which of the following is not a typical characteristic of cancer cells? Right? Review question. Loss of cellular self-destruct mechanisms, unlimited replication, autocrine stimulation, or decreased responsiveness to growth signals. Which one is not characteristic of cancer cells? How many of you say A? How many of you say B, C, and D? Okay. D's have it. So they are more responsive to growth signals. If any growth signals are there, cancer cells respond. So they have an increased responsiveness. Autocrine stimulation means that they can actually create their own VEGF or growth factors that would trigger them to migrate and metastasize. That absolutely does happen. All right, questions over cancer before we move on. Yes?
So I have a question, and 120 grams is 4.2 ounces.
Oh, thank you.
And I have a question, like,
4.2 ounces.
yes.
4.2 ounces a day?
That's what it
That
says.
must be like shots or something, right?
Because
Yeah, because that would be like 4 ounces would be like 4 shots, wouldn't it? An ounce is a shot, is that right? Okay.
Probably pure.
1.5 is a shot? Oh. Wow. I should come see you as my bartender. And then you had a question, and then over here.
And my question was, because like you recently on YouTube, whenever you like open a video, they're just showing videos talking about that vapes are actually as bad as smoking, because they were like, yeah, vapes are like a vape. What's the thing that they use?
Propylene glycol?
No, the chemical that they put inside in order. Yeah, because I heard that one is like 28 cigarettes.
In a jewel pod. In a pod.
Yeah.
Yeah, one pod is 20 cigarettes.
So
That's the one pod is a pack.
Yeah.
that's the nicotine to be exact.
The nicotine, the amount of nicotine, is what you're saying, yeah. I mean, the argument that those in favor of vaping will use is you get all the nicotine, which is addictive. They're not arguing that nicotine's not an addictive substance. It'd be hard to argue that, but they're saying you get all the nicotine, but you don't have the carcinogens, which is true. You do have contaminants, and there might be unknown contaminants that have carcinogenic activity. We just have to figure that out. Does that make sense?
Yeah.
So in order to become a carcinogen, it's like we know it has carcinogenic behaviors and activities because of prior knowledge. And because when something is so new, you may not have all that information. That's the reason, I mean, even propylene glycol, I think is what they use to make the plume. It's one of the agents that can be used to make the plume. And there's some psychology, is, you know, some people don't need it, some people like to see the smoke because it's sort of that psychological interaction that they have, which is part of the dependency. There's a behavior associated with it, an addictive behavior, not just addiction to the chemical. But there's been a lot of success in weaning smokers who cannot quit off of cigarettes and moving them over to vape. And it's hard to argue that that's not a better solution than just sticking with cigarettes. You with me?
Yeah.
Because if they're going to smoke cigarettes the rest of their life, it'd be probably better for them to move over to vaping, at least for what we know of now. But the bigger problem is the introductory behavior to people that don't ever do anything, and they're going to try it, and now they're going to get hooked on it, and they wouldn't have done it. If the burden was cigarette smoke and all of the bad publicity around cigarette smoke, they may never have tried it. But now that there's this lower burden of entry of maybe it's a safe alternative, they're going to try it, and they get addicted to the nicotine, and they never would have before because there was never that option. So, I mean, there's hard arguments on both sides. I mean, I'm not trying to tell you how to vote tomorrow. I don't even think there's anything on the ballot. But, you know, you can see both sides of the argument. It's a tough one. It's not one that we're going to solve right now. But in your lifetime, you're going to learn a lot more information about this topic. Yes, sir.
I was just going to clarify, standard alcohol drink contains about 14 grams of alcohol.
Say that one more time.
A standard drink contains about 14 grams of alcohol, so like 120 grams is about 10 drinks per day.
10 drinks a day. Yeah, that's pretty high, I think. Yeah, man. Yeah. But like, isn't a Long Island iced tea isn't it got like
It has like 6 different types
4 or 5 different alcohols in it or something?
6 different types
What?
of
Iced tea?
iced tea in that. Like, why do they call it a Long Island iced tea? Yeah, I haven't seen anything along those lines, but maybe I haven't